Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 47th episode of Optometry series. I'm very happy to welcome my team members, Ms. Meenakshi and Ms. Anshima. Hi, ma'am. Yes, Anshima, ma'am. So tell us who's today's moderator and what is the topic. So we all know that we are into the back to basics section already. So this is another part of back to basics, and we're really getting good opinions and good comments from all the people in the optometry fraternity. We are so happy about it. So, what is today's topic? Why did you come up with the topic? And who's the moderator, ma'am?
Okay, so today's topic is we're going to learn about basics of slit lamp. As we know that we're going step by step. So we've completed with history taking, refraction, and then doing a simple procedure. So the next procedure that the patient undergoes is basically the anterior segment evaluation. That's what we're going to focus on today. And for that today we have with us Ashwini. She's my classmate from ESO, and I've known her since 2005. So she's a wonderful person, a very good teacher, and she takes a lot of time. She's very patient in explaining each and every detail. So, and she's an optometrist working at Ashwini Eye Care. So, it'll be really good when a clinician explains from her point of view how do we see a patient in a scenario where we have to diagnose the condition. So, I think nobody better than Ashwini would have been able to do it. So, thank you, Ashwini, for joining us. Over to the MC for today to introduce our moderator.
A very warm welcome to everyone. I am Meera Jasmine, studying first year bachelor's in optometry at Dr. Agarwal's Institute of Optometry. It's an honor to introduce today's moderator, Ms. Ashwini Ma'am. Ma'am began her career in 2009, shortly after graduating from the Elite School of Optometry. With a passion for excellence and a heart dedicated to patient care, she began her independent practice at Ashwini Eye Care. Her name became synonymous with trusted optometric care, attracting patients who sought her unique blend of professionalism and compassion. She pursued her master's in optometry and an MBA in hospital administration. Ashwini Ma'am's passion for optometry extended beyond the clinic as she ventured into academia, serving as an assistant professor in the Department of Optometry at Saara Medical College for over 3 years. With nearly 15 years of experience, Ashwini Ma'am has become an expert in clinical optometry and ocular diagnostics, specializing in visual fluids and OCT. We are so glad to have you as with today, ma'am. The presenter for today is Ms. Reslin Dency, studying third year bachelor's in optometry and the technical team member of optometry series at Dr. Agarwal's Institute of Optometry. Ms. Reslin, please start your presentation.
Thank you, Meera. Back to basics, slit lamp techniques and tonometer. Slit lamp biomicroscope. Slit lamp biomicroscope was invented in 1911 by Gulstrand. It is named so because it enables the practitioner to observe the living tissue of the eye under magnification in slit and wide view. The term slit lamp was coined because of the slit lamp emitted by the illumination system. The slit lamp is sometimes called the biomicroscope. The instrument combines variable magnification with controlled illumination. Parts of the slit lamp. It contains of three parts: mechanical support, observation system, and illumination system. Illumination system contains of lamp housing unit, slit width and height control, neutral density filter, cobalt blue light, red free filter, field size control, diffuser, and prism. Types of illumination. Types of illumination contains of three types: diffuser illumination, direct illumination, and indirect illumination. Direct illumination contains of optic section, parallelopiped, conical beam. Indirect illumination contains of retro illumination, specular reflection, sclerotic scatter, and tangential. Magnification and uses. Low magnification 7x to 10x, we can view general eye. Medium magnification 12x to 25x, structure of individual layers. High magnification 30x to 40x, we can view in detail. Diffuse illumination 45-degree angle between light and microscope, fully open slit, diffusing filter, variable magnification, low to high. Overview of adnexa, conjunctiva, cornea, sclera, iris, and pupil. These are the disease condition we can view by diffuse illumination. Direct illumination. Observation and illumination systems are focused at the same point. Variation in the angle of illumination are made provided they share the variation in the angle of illumination are made provided they share the same focus as the observation system. Low to high magnification can be used to observe the cornea. Variation in the width or height of the light. The source will be given the following: optic section, pallopiped, and conical beam. Optic section. An optic section is a thin, high intensity light of used in slit lamp biomicroscope to provide a cross-section view of transparent ocular structures. This technique enhances depth perception and allows for detailed examination of different layers of the cornea, lens, and anterior chamber. The biomicroscope light source and positioned at an angle to create a cross-sectional image. Optic section, we can view cornea layers, lens layers, and Van Herk gradings. Clinical application. Corneal condition identifies keratitis, corneal thinning, foreign bodies, and dystrophies. Anterior chamber assessment detects inflammations, lens examination assess cataract and lens dislocation. Angle estimation used in Van Herk gradings to assess the anterior chamber angle and the risk of angle closure. Pallopiped. Pallopiped illumination is a slit lamp technique that creates a rectangular column of light to provide a three-dimensional view of transparent and semi-transparent ocular structure. A moderate width slit lamp is used. The illumination system is positioned at an angle to a microscope to enhance contrast. A wider angle provides better depth perception. Conical beam. A conical beam is a focused circular beam of light used in a slit lamp biomicroscope to examine the anterior chamber of cells and flash, which indicates inflammation. It is a critical technique for detecting subclinical anterior chamber reactions. The beam is adjusted to a short circular or square shape, and the illumination is set to maximum brightness to enhanced contrast. The magnification is increased for better visualization. Pallopiped and conical beam. Pallopiped we can view in cornea in 3 dimension. Indirect illumination. Observation and illumination systems are not focused at the same point. Focal light beam is directed adjacent to the area of observation. Vary angle of illumination. Slit beam is offset. Vary beam width and low to high magnification. Retro illumination. Object of interest is illuminated by light reflected from the structures behind it. Vary angle of illumination. Moderately wide beam. Slit beam is offset, medium to high magnification, reflected light from iris or fundus. Specular reflection. Specular reflection uses a mirror-like reflection to examine the corneal endothelium or tear film. The angle of incident light is equal to the angle of reflected light. We can observe endothelium tissue, tear film debris, tear film lipid layer. Sclerotic scatter. Illumination of the cornea by total internal reflection of a wide angle light source. The light beam is directed at the limbus region while observing the cornea. We can observe epithelium edema, corneal scar, foreign bodies in the cornea. Tangential illumination. Large angle of 70° to 80° between illumination and observation system. We can observe iris, fracture, tumors, general integral of the cornea and iris. Van Herk grading intro. The depth of the anterior chamber angle was established by a Van Herk technique. It is performed using a sharply focused optic section positioned on the cornea 2 mm inside the limbus. The cornea will be seen in cross section with the slit beam reflected off the front surface of the iris in the presence of an open anterior chamber angle and clear aqueous humor. The anterior chamber is optionally empty and appears as a black space between the cornea and iris. The width of the space formed by the anterior chamber angle relative to the width of the corneal thickness is used as the measure for the angle width estimation. Procedure purpose to measure the anterior chamber depth using a slit lamp. The relative space formed between the iris slit and the corneal thickness is assessed for the anterior width estimation. Requirement slit lamp procedure. Slit lamp adjustment to be made. Angle between illumination system and viewing system should be kept at 60 degree. Narrow the width to at the optic section and instruct the patient to look straight ahead. Focus the beam sharply on the cornea at the very edge of the temporal limbus. We can notice corneal thickness and orange narrow slit reflected from the anterior surface of iris. Compare the gap formed between the iris slit to the thickness of the cornea. The shadow is the darkest interval between the light on the cornea and the light on the iris that represents the official empty awkward in the anterior chamber. Gradings. The peripheral anterior chamber depth is combined to the adjacent corneal thickness and the angle width is graded as four gradings are there. Grade 4 wide open angle, grade 3 mild narrow angle, grade 2 moderate narrow angle, grade 1 extremely narrow angle, grade 2 closed angle. Hints and tips. Errors in angle estimated may occur if the patient eyes are not in primary gaze. The most common mistake that will be result in angle overestimation is if the optic section is not placed far enough peripherally at the cornea's sclera junction. The beam should be at the extremely 60 degree to the observation system. Notice practitioner often have too wide a beam. It should be just thick enough to avoid extension. Recordings. We should record Van Herrick will be like this. Anterior chamber depth using Van Herrick technique, OD grade 4, OS grade 4. Lid aversion procedure. Ask the patient look down, place your forefinger near lid margin, gently pressure and lift. Lashes comes into a contact with forefinger. Hold the lashes. Apply gentle pressure inward near the lid, not on the lashes. Then twist it up. Papillae versus follicles. Papillae, allergic and bacterial, red dots of varying size and non-specific. Follicles, toxic and viral, avascular, white nodules. Filters used in slit lamp. Cobalt blue, blue filled circle enhance the view of fluorescent dye. Red free, green filled circle used to enhance the view of blood vessels and hemorrhage. Neutral density circle with a hasted line decreases the maximum brightness for photosensitive patient. Yellow filled circle for good contrast enhancement for green staining. Diffuser, a filter placed on illumination source used for general observation of the eye. Head observation built into a most state lamp decreases the patient discomfort. Tonometer. Tonometer is the procedure performed to determine the tonometer is a procedure performed to determine the intraocular pressure. Types. These are the types for tonometer. Indentation tonometer. It is the based on fundamental fact that puncture with indent a soft eye more than the hard eye. The indentation tonometer is current used that is Schwartz. It was derived in 1905 and continued to refine in through 1927. Patient should be anesthetized with a 4 drop of lignocaine or 0.5% of propagaine. With the patient is a supine position, looking up the fixation target, while examiner separates the lid and lower the tonometer plates to rest on the cornea so that plunctor is free to move. The 5.5 gram uh, weight is initially used. If the scale readings is 4 or less, adding weight, additional weight is added. Advantages: simple technique, elegant design, portable, no need for slit lamp or power supply, reasonable priced, widely used tonometer. Application tonometer. The concept was introduced by Goldman in 1954. It is based on Impet-Frick law. It states that the pressure inside an individual sphere is placed T flattened. P is equal to F by A. Technique: topical anesthesia, staining tear film with fluorescein. The cornea and biprism was eliminated with Gopal blue filter. Biprism just touches the apex of cornea at the point two fluorescent semicircles are viewed through prism. These are the interpretations. Potential error: patient related, thin cornea, thick cornea, astigmatism, irregular cornea. Thank you.
Thank you so much, Dency. Ma'am, now I request you to add your inputs, ma'am.
Yeah. Thank you. So at the outset, I would like to really thank Ms. Anshika, Ms. Gomati, Ms. Meenakshi, Ms. Meera Jasmine, and if I missed someone, for the very warm welcome and for all the coordinations. And Ms. Reslin, yours was a very nice presentation, an extensive one, definitely. I think half my work is done, I guess. So I would just like to add on few clinical points, maybe just few points which I have been observing over the years, which are, like missed out very easily, especially by students. So can I share my screen? It's
Yes, ma'am.
disabled.
Oh, okay. Just a minute, ma'am. Ma'am, can you try now? Yeah.
So is the screen visible?
Yes, ma'am, it's visible.
Is the screen visible, Meenakshi?
Yes, ma'am, it's visible, ma'am.
Okay. Yeah, I'm not
Yeah,
able
ma'am.
to hear you. Okay. So as I told you, I would just like to add few more points, but before going into slit lamp and tonometry, I would just like to ponder upon why is this slit lamp examination very important for optometrists to excel in. So the main thing which I feel is whether we are doing an independent practice or we are attached to a hospital where we send our patients to the ophthalmologist, still we are supposed to do a very good slit lamp examination as it is a part of the comprehensive eye examination. And it is also used to identify certain emergencies, decide whether we need to dilate the patient or not. So for all these main things, we need to definitely do a good, proper slit lamp examination. And sometimes when we are doing an independent practice, your slit lamp examination gives a very good idea for you to counsel the patient on their conditions when they have to go in for an ophthalmologist evaluation or whether they can wait or whatever it is based on their cataract status or anything. You can give a very elaborate counseling for the patient and also to correlate between the patient's vision and any other findings that is found in slit lamp examination. You need not wonder why the patient's vision is not improving to 6/6, for which you might have an answer during your slit lamp examination. So I think it's very, very important, and I really appreciate Dr. Agarwal's team to have such a very basic topic because it's definitely important. So before we start the examination as such, I would like to insist on few slit lamp adjustments. Again, I've observed that it is easily missed out. We just tend to make the patient sit in front of the slit lamp, make them place their head and just like that start doing the slit lamp examination without making certain basic adjustments, which might give discomfort to the patient. And we might also sometimes miss out on few important conditions. So always before starting any procedure, it is very important to explain the purpose and procedure of the procedure to the patient. So this, first of all, relaxes the patient to a great extent, be it slit lamp or for tonometry. It's very important to inform the patient what we are going to do, which will definitely put the patient at a calm state of mind. So adjusting the height of the table and adjusting the chin rest, making sure that the canthus is, coinciding with the mark on the stand of the rest. So we need to make sure that all these adjustments are done for the sake of patient's comfort. Apart from that, for our sake, we have to make sure that we change the IPD to ensure our binocularity and also to neutralize the eyepiece so that we correct for the refractive error. I think these are very basic, which is very easily missed out by many of our students. So when you do slit lamp examination, Ms. Reslin gave a very elaborate and very good explanation about what all has to be done. Just to add on few points, ensure that we give a fixation to the patient. Otherwise, patients will tend to, keep moving their eyes here and there without knowing where to see. So it's very important to give the fixation. What fixation has to be given? It usually varies from one person to another. Generally, you have a fixation light attached to the slit lamp. You can give that, or you can tell the patient to look into your ears or whatever. But give a very good fixation to the patient so that they will know where should they look. And make sure that we do a gross examination, both patient's eyes closed and open, because sometimes we might find certain conditions in the eyelashes which can be missed when we just do an open eye examination. So it's very important to start the examination with the patient's eyes closed. And about eversion, we saw all the eversion techniques and all that. We might find some surprises if we miss out on eversion of the eyelids. And also, it is very important to do the examination in all the gazes. Always make the patient to have, superior gaze, inferior gaze, medial gaze, and the temporal gaze, so that we don't miss out any conditions. Especially, it is important to, make the patient do an inferior gaze and examine the superior cornea and superior iris, superior bulbar conjunctiva. Sometimes we find surprises even at that in those regions. And doing anterior chamber depth grading, all these are important. There are certain quantitative measurements that you can do by changing the slit height and the width. So you have an option in the slit lamp, which I'll be showing you in the next few slides, with which you can change the slit height and the width, and you can make measurements of, say, cis or, pterygium, pinguiculars, such kind of findings. You can document the measurement so that you can assess the progression. It will add on great value to your documentation. Okay. So first, as I told you, on eye closure, when you examine the eyelashes, sometimes you can even find this theriasis palpebrum. This can sometimes be missed out when we, do only an open eye examination. Similarly, on not doing lid eversion, you can miss out some small chalazion or some foreign body which is in the tarsal conjunctiva. And sometimes you can miss out, few corneal conditions in the superior cornea, or you can miss out your YAG peripheral iridotomy opening if you don't just push up the upper eyelid and look into the superior corneal region and the iris region very clearly. So you can either tell the patient to look down to examine like this, or you can, push up the upper lid and examine, so that you will be able to find out these conditions, which is usually hidden by the upper lid margin. And one thing which is important when we look into YAG PA is about its patency. So generally, how do we check for the patency of YAG PA? You usually keep your illumination in slit beam, like optic section, and you place the illumination system and the viewing system coaxially, and you put the light through the pupil, and you will observe that the light is seen via the PI opening. The light has to, get reflected via the PI opening. So that's how you check for the patency. So it's not only about looking at the black spot in the iris, which says that there is presence of YAG PI. We should also document whether the PI is patent or not. That is also very important. So I'm not going to go into the Van Herrick grading because she has given us a very detailed explanation on how to do that. I'll just skip these. And this is the thing about the adjustment of slit height and the slit width. You can also change the orientation of the slit like this. So you can see this knob in most of the slit lamps, which is used for adjusting the slit height. And when you turn this system, like to the right and left, you will be able to change the orientation of the slit like this. So I'm going to this level of basics because I've seen few students who are not able to identify how to change the height or how to change the orientation of the slit. Sometimes changing the orientation of the slit is very important when we do measurements of these chalazion or pinguicula. You will be measuring the height and the width of any cyst or so. So you'll have to change the orientation to measure accordingly. So this is another important thing for your quantitative measurements. And fluorescence staining is also very important. Whenever necessary, it is important to do the fluorescence staining. You can pick up conditions like your conjunctival staining in case of very severe dry eyes. You can pick up foreign bodies and also the related corneal abrasions. Sometimes we might not, in case of very minute hair, very commonly noted ones are the caterpillar hair, which can get stuck in the palpebral conjunctiva or the tarsal conjunctiva. We can miss it out in our usual yellow filter. So when you do a fluorescence stain and observe in your blue filter, you will be able to pick up such kind of foreign bodies also. And as we know already, it is helpful in applanation tonometry. And it is also an important thing that we do during our contact lens fit assessment, RGP fit assessments. So documentation, coming to documentation. So why is this documentation important? I've seen different types of documentations done. Usually, I prefer a documentation where you draw the structure and you document properly instead of just writing down what all we see. So just listing down what all we see. Instead, if you do a proper diagrammatic representation, it will be very helpful. Mainly not only during the assessment when the ophthalmologist is going to see next in the hospital-based setup, but also when we call back the patients for reviews to assess the progress, or even when the patient comes to us after 1 or 2 years, this will be your baseline documentation based on which you can compare your next year's findings. So it is very important to have a very good documentation system. And wherever you find some abnormal conditions, it is very important to note the size, the location, the nature of the abnormality wherever applicable. So one example about documentation where usually it is missed out. Few people, they just monotonously draw the pupil and the lines, around the pupil just like that without knowing the meaning of it. So always make sure that the pupil size, the pupil shape, the pupil's reaction to light, all are noted properly before doing this kind of a documentation. If the pupil is not regular and round, you're not supposed to draw a round like this. You're supposed to diagrammatically represent the shape of the pupil. Similarly, if the pupil is not reacting to light, please do not, draw these 4 lines around the pupil, because these lines are meant that the pupil is reacting to light. So such kind of, small things matters a lot in documentation. So just for one example, if a patient has ptosis, you can just drooping of lids, you can represent like this. And this drooping, you have to just make sure that whether the drooping is, across the visual axis or it is not crossing the pupil, you have to draw accordingly. Again, this position of the lids, it matters a lot. You'll have to understand how much is the drooping by just seeing the slit lamp diagram. And you have color codings. So you have many references for these color codings. You can just go back to your books and, reference articles to know what colors are used in slit lamp diagrams. The common colors which are used are black, blue, brown, red, green, and yellow. So for each of the findings, you will be using different colors. So I just wanted to, put up few examples of these color codings. For different corneal conditions, you use usually blue, red, and green. Sometimes you use yellow, especially for hypopyon or such conditions. You can use yellow color. For congestion, for hemorrhages, you use red color, as we know already. For dystrophies and for edema, you can use blue color. The patterns used for each of the condition is usually different. You either use a wavy line in case of the decimate folds. If it is a edema, if it is a diffuse edema, you use a blue color shading which is shown here. Or if it is just epithelial edema, you just show it in blue color as small circles. So you have different formats for different conditions that you can note. So this I have discussed already. You have few quantitative assessments and few qualitative assessments. So in case the condition noted is something which can be quantified, please make sure that you give the quantification. Like, for example, the number of folds or number of microcysts that you notice, or the size of the opacity, whatever it is, you, if possible, give a quantitative assessment. And you have grading, subjective gradings for papillae, follicle, all those gradings which you have. So give those gradings wherever applicable. And something which you can explore, something very interesting for the student community also to explore, is slit lamp photography with the help of a mobile itself. So I think it will be good for you guys to, have your mobile and try to take slit lamp photographs amongst each other. So it's quite interesting to take a very good picture with just a mobile and the slit lamp. So you can just explore that. Moving on to tonometry. So again, explanation of the procedure. So after instilling the anesthetic agent and after instilling the fluorescent dye, please examine the corneal health, corneal status. So in case there is some aberration that you missed during the slit lamp examination, or in case there is some active condition which indicates that you're not supposed to do an AT, so please make sure that you examine the cornea after you instill the fluorescent dye and ensure that the cornea is clear and there is no contraindication for AT for the patient. And we saw the slit lamp setting already. So at least during the initial period, I feel it will be easier to do AT in a dim room illumination because of the contrast enhancement. So at least initially you can try doing in a dim room illumination, but it's of course not a mandatory thing. It's not that you cannot do AT in a normal room illumination, but dim room illumination makes it easier. So once you complete your IOP measurement, the procedure was explained by Ms. Reslin. So once that is done, please ensure that you re-examine the cornea again for any aberration. Sometimes we might go a little more, we might move forward the AT head a little more than required, and there is a possibility that the cornea gets aberrated. So please re-examine the cornea for any such aberrations. After which, ensure that the AT head is disinfected. The commonly used agent is bacillocid. And for documentation, you need to just multiply the reading by 10 and document. So this is a picture which shows a typical epitheliopathy, which is caused by, the excessive movement of the AT head. So a typical round structure. This sometimes the patient will be asymptomatic, sometimes the patient will be very symptomatic. So you have to assess the cornea after completing the procedure and make sure that a proper referral is done according to the severity of the aberration. So the sources of error, I feel this is something very, very important for us to have in mind, because whatever IOP reading we put across in the documentation process, we should also ensure that that is the actual IOP for the patient, because sometimes in case the patient is a glaucoma suspect or is already a glaucoma patient, then sometimes the treatment modality also depends on the IOP values, right? So we have to ensure that there is no error in the estimation of IOP. So very commonly missed out thing or error that can happen during IOP estimation is the positioning of the patient. So in case the patient is not positioned comfortably, or in case the patient is anxious and doesn't breathe properly, or in case the patient is having, wearing tight collared dress or something like that, it can definitely cause an overestimation of the IOP. And one more thing which I have usually observed is that if the patient is really anxious, there will be excessive squeezing of eyelids or excessive, blinking of eyes. So again, this is a place where your instructions at the start of the procedure plays a very vital role. So you have to just put the patient at peace so that our job is also made easier. Okay. And a thicker cornea and thinner cornea, it plays a very vital role in the estimation of IOP. So if the cornea is thicker than normal, because of the excessive applanation required, excessive force required to applanate the cornea, there will be overestimation of the IOP and vice versa. Whereas if there is corneal edema, there will be underestimation of IOP because of the pathological edematous condition and not the natural changes in the biomechanics of the cornea. And also, in case if we do a repeated measurement, okay, say for example, I do the IOP measurement once and I find that I'm not very sure about my value. So I just do it again and then I just do it again. You will see that there is a decline in the IOP value if you keep doing it again and again. So better to avoid that, and to not always open the eyelids wide with force. Okay, in case the patient is really not cooperating, just a slight force to hold the eyelashes and just slight elevation of the eyelid and not a very forceful opening or widening of the palpebral fissure, because again that will give an overestimation. If there is corneal distortion or if the AT head comes in contact with the eyelashes of the patient, all these will give us inaccurate IOP values. If the AT instrument is not calibrated also, we'll start getting an inaccurate measurement. So all these plays a very important role when we, check the IOP for the patient. And we are not supposed to do applanation tonometry when there is open wound, open injury, open ocular injury, when there is active infection. If we know that the patient is sensitive to a topical anesthetic or there is some corneal abrasion or ulcer, if there is fluorescent staining positive, then please avoid doing AT. And just a touch on non-contact tonometry, because this is being used very commonly nowadays. So the main advantage is that it is not invasive. Patient cooperation is, less required in this method. There is a small challenge in non-contact tonometry, which is about the fixation of the patient. So since the patient has to see a very smaller target within a small lens, there is a small disadvantage when you do non-contact tonometry. In case the patient has poor vision, there can be a very varying fixation by the patient, which can make the procedure a little more challenging. Otherwise, it is a bliss to do non-contact tonometry usually. And documentation, we have to always remember that you have to mention the method with which you're doing the tonometry, whether it is applanation, whether it is Goldman applanation or non-contact or Schiertz or whatever method, please mention that, because tomorrow when we do the IOP measurement again for reviews, you have to at least have a correlation with the method done, because there are small variations between the methods used. You have to mention the time for reasons obvious. IOP measurements varies through the day, so you have to definitely mention the time and the units. And in case you have done some, adjustments while doing IOP measurement, like, you had to open the eyelid wider for the patient, or in case the patient was holding the breath, or in case the patient didn't cooperate properly, or in case you noted that the patient's corneal thickness is more, any such comments, it's always important to note it along with the documentation of your IOP. Yeah. Okay, so I'm open for questions. Any questions? Meenakshi?
Yeah, ma'am. Can you hear me, ma'am?
Yeah,
Am I
a
audible?
little louder.
Is it better now, ma'am?
Yeah.
Students have narrated certain questions to us, ma'am. I'll read it for you.
Yeah.
The first question is, what does modifications like slit beam or slit height makes the view of slit lamp? How does it matters to view a optimal view of a structures?
Are you asking how does it matter during slit lamp examination? The last part was not audible.
Yeah, how
You
is
mean
it
how does the slit height and slit width
beam with
adjustment matters during? Okay. So as I mentioned already, sometimes when we want to, the main procedure when we adjust the slit height is during the conical beam setting, when we want to observe the anterior chamber reaction for cells and flares. That is one regular thing which we do. Otherwise, when you change the slit height and slit width, you usually use it for measurement purposes, and also like for the when you are not very sure with the very if the slit beam is very high, I mean, if it is kept at the maximum height, then you might not be able to assess few conditions. So, or you might not be able to measure few conditions accurately. So it's mainly adjusted for the use of measurements, and the daily routine is for assessing the anterior chamber reaction, the height adjustment. The width adjustment, we adjust from diffuse illumination to optic section. So that's again a regular practice which we do for all the patients. We have to adjust the slit width for all the patients to assess all the structures of the eye.
Thank you so much, ma'am. I'll proceed with the next question. How to differentiate between cells and flares in the anterior chamber?
Okay. So for both observing the cells and the flares, we usually have a dim room illumination, and we put the slit lamp setting into a conical beam. So conical beam is when you keep the slit height to the minimum possible. Okay, and you just focus both the you just focus in the anterior chamber area. You will have to keep the illumination system and viewing system in an angle of around 60 degrees. So you will see a gap between the yellow reflex and the white reflex, right? So when you see small powder-like structures floating in between these two beams, those are called as the cells, okay? And due to Tyndall effect, you see a flash of light between these two reflexes, which is the flare. 1 minute, yeah, which is the flare. Okay, so aqueous cells and flares usually we observe in anterior uveitis. So sometimes you will be able to grade the cells and the flares. So you grade it as cells plus plus or plus or plus plus plus, and the similar thing for flare grading also. So it's conical beam. Dim room illumination is very, very important in this, and you focus in the anterior chamber area, place the viewing system and illumination system in 60-degree angle, and observe the anterior chamber area for powdered structures and for light reflex.
Thank you so much, ma'am. The next question is, how does specular reflection help in assessing corneal endothelium?
So specular reflection, clinically, I feel we don't, usually use it to the maximum extent. It requires a very high magnification to really, see the endothelial health. So instead of generally, clinically, I'm talking. So instead of, depending on specular reflection for assessing the corneal endothelium, we generally depend on other modes of evaluation, like, using your SPM. So in case of a slit lamp examination, if a very high magnification setting is, available, then you will be able to see, very obvious defects of endothelium. You might not be able to see very minimal, loss in cell count, or, this polymegathism, pleomorphism. All these things might not be really visible, but you will be able to see more of major defects in the endothelium in a slit lamp examination using specular reflection. Otherwise, more than the slit lamp examination, you go in for your SPM for assessing the corneal endothelial health.
Thank you so much, ma'am. Next question is, if there is guttata, how will it be seen in slit lamp?
So this is kind of related with the previous question, I guess. So you'll be seeing it like a defect in the corneal layer, an empty space kind of thing in the corneal layer. So you will be you will be able to see that when you keep a optic section, and based on the location, you will have to assess. So this brings to the point where the slit lamp examination has to be done, like extensively. You might miss out if you do a very gross examination. So once you keep the optic section setting in your slit lamp, it is very important to do the examination from, say the temporal side to the nasal side across the cornea, and look out for any empty, blackish spaces kind of thing in the corneal section, and again in high magnification.
Thank you, ma'am. The next question is, what modifications are required when examining an uncooperative patient with a slit lamp?
Uncooperative patient with the slit lamp, modifications. Okay. Slit lamp modifications as such, I'm not sure what they are meaning by this question. One thing which you can do is to get the help of the attender. So by uncooperation, usually one thing which is possible is with the pediatric patient, where they don't place their forehead and the chin properly in the rest. So we can ask the attender to, hold the patient from behind with a slight force so that their forehead is rested on the forehead rest and the chin is placed on the chin rest properly. And apart from that, if the patient is, another type of uncooperation is by blinking too many times, or, closing the eyes lots of times. So we can put a very slight pressure to, open the eyelids and do a very quick examination in such cases without, taking more time. And if the patient is not fixating properly, we need to try giving different types of fixations, or, we need to keep talking to the patient, making the patient, involved in the examination. You can tell the patient to look at our eyes or look at our mouth or look at our ear, and, keep changing the fixation so that the patient will cooperate at one point or the other. So commonly, I feel it's either resting the face or excessive blinking, closure of eyes, or, loss of fixation to be the very common uncooperation from the patient side. If there is any other specific uncooperation that any of you have observed, you can ask me. I can suggest some modification. Otherwise, I think these are the adjustments that we can do. Otherwise, slit lamp modification, I'm not able to think anything else as such.
Thank you so much, ma'am. Those were the questions asked by students.
Okay.
We are done with Q&A, ma'am.
Sorry?
We are done with Q&A.
Yeah, okay. Yeah.
Thank you, ma'am. I request Gomati to take over the session.
So thank you so much, Meenakshi, for the Q&A session. Anshuman, would you like to add any points now?
I think it was very comprehensive. Thank you so much, Reslin. Thank you so much, Ashwini, for taking out time to give us inputs about the small aspects of how documentation is also equally important, rather than just knowing how each technique is done. So I think if we put together Reslin and Ashwini's presentation, it is a complete basics to how to use a slit lamp and tonometer. So thank you to both of you. Very sorry for the glitches today, Ashwini, but really it was a wonderful session. Once we upload it in YouTube, we'll let you know. Thank you so much.
Thank you.
Over to you,
Thank
Gomati.
you.
Excellent. So once again, sorry, Ashwini ma'am, we didn't expect this glitches in the last minute.
No problem.
Thank you so much for being so kind and patiently answering for all the questions, ma'am. Thank you so much, ma'am. We would like to host you on another wonderful platform here at Dr. Agarwal's, ma'am.
My pleasure. Thank you all so much for the opportunity given.
Thank you, ma'am. Yes, dear audiences, thank you all for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with all your friends. To know more about the happenings at Dr. Agarwal's, please do follow our Instagram, YouTube page, as well as LinkedIn and on Facebook also. So thank you all so much. We'll meet in the next episode. Thank you, ma'am.